So, good afternoon, everyone, and a warm welcome to today's session in the Thursdays webinar series of the ERN-EuroBloodNet. My name is Christophe Woodgebur, and I'm honored to host our discussion today for this webinar dedicated to advancing care for rare hematological disorders. Today's presentation is entitled Updates in the Treatment of AL Amyloidosis and Monoclonal Gammopathies of Clinical Significance, an especially timely topic in our lymphoma and plasma cell disorder subnetwork. We have the privilege of welcoming Bertrand Arnulf, Professor of Clinical Immunology at the Université Paris Cité and Head of the Immunology Hematology Department at Hôpital Saint-Louis, Paris. Before starting this webinar, I would just like to remind some housekeeping notes. Your microphone will remain muted during the presentation. Please note that this webinar is being recorded and will be published on YouTube after the end of the session. You can submit your questions via the Q&A chat box at any time, and Professor will answer the question at the end of this presentation. This program is accredited by the European Board of Accreditation in Hematology, EBA. You can earn 1 CMA credit per webinar attended. To receive the credit, you must attend the full webinar, complete the feedback survey at the end, have an active EBA account, and use your EBA email in the survey that you receive after the session. You can also use the AI translated caption provided by Zoom in any of your languages. This webinar will be provided in English. Professor Bertrand Arnulf, the floor is yours. Thank you.
Well, thank you very much for this kind introduction. And I think I can share my screen and start. I think you can see the slide.
Yes.
Yes,
We
thank you.
do.
We will start with the MGCS concept, monoclonal gammopathy of clinical significance. As you know, it is now well known, first described in 2006 by Giampaolo Merlini, stating that outside of tumor burden and symptoms linked to the tumor burden, some small clones with small tumor cells can lead to organ threat and deterioration, and might be as a consequence to start the treatment against the clone. And as you know now, outside of MGUS, outside of symptomatic multiple myeloma, we have MGCS, and it is now that like the MGUS are the good, the multiple myeloma are symptomatic are the bad, and between the ugly for the MGCS, presenting as a small and smoldering clone, but with large consequences. So the second paper was from the Jean-Paul Fermand in 2018, and I think it's very important because if you want to have to understand this large number of disease, you have to consider the pathophysiological classification of those disease. And you have a first group, large group with depositis and precipitation. Of course, organized or non-organized, and you know, organized, there are fibrillar organized deposition disease. It's AL amyloidosis, microtubular, like cryoglobulinemia, for example, or crystal deposition, in proximal tubulopathy, for example, and non-organized light chain deposition disease, or PGN-MID. The second category is the autoantibody activity of the monoclonal components, but also all immune complex between the monoclonal immunoglobulin and other protein. And the third is the cytokine overproduction, either by the clone or by the microenvironment. And the fourth category is quite large number of diseases with unknown mechanism, but we know that the monoclonal component is linked to those to the symptoms. And you can see the number of publications regarding MGCS, starting from the original paper in 2006, and then the second increase in 2018 after the Jean-Paul Fermand paper. I think the major diagnostic challenge are the early detection, because it is very important to detect early the disease to prevent organ deterioration. The second is to prove the clone existence and to categorize the clone. And you know, it's very important to distinguish between plasma cells and lymphoplasmacytic disorder, because not the same treatment. And also it is very important to exclude fortuitous association, because you know monoclonal gammopathy is very frequent with age. And for example, there is a large proportion of patients with monoclonal gammopathy and transthyretin amyloidosis. So it's not AL amyloidosis, but there is a monoclonal component in the serum. So having said that, we now discuss the therapeutic consideration, and also it's very large therapeutic attitude. You can have only surveillance when their symptoms are mild or just cosmetic. You can have non-specific treatment, IVIG or anti-cytokines or anti-complements or steroids, but mostly you have to target the clone, distinguish between plasma cell and lymphoplasmacytic clone. And you have also treatment as transplantation for renal, for example, or heart transplantation for AR amyloidosis. So there is a lot of treatment targeting plasma cell. There is a huge progress, as you know. The three main class are IMiDs, proteasome inhibitor, and anti-CD38 antibodies, but also immunotherapy with monoclonal bispecific antibodies and CAR T cells. Of course, with each treatment has her own toxicities. And we will focus now on the new therapeutic tools as immunotherapy for those diseases, especially bispecific antibodies. We were not talking much about ADCs, some words about the CAR T cells, but I think the main therapeutic updates is regarding bispecific antibodies in those diseases. And as you know, there is two there are three main bispecific antibodies targeting BCMA, teclistamab, elranatamab, and linvoseltamab approved, and other in development. And the three bispecific have demonstrated efficacy in very advanced relapse refractory multiple myeloma. And of course, we think to use those therapy in even in MGCS. And also there are CAR T cells targeting also BCMA, ide-cel, cilta-cel, and some academic CAR T cells like RE2H in Spain. So in the next slides, I think I will take an example of each categories of MGCS, and then have an update on the treatment, the use of the new immunotherapy treatments for each disease. So the first category is the depositis precipitation, and as you know, it's mainly MG-RS regarding renal depositis, as the IKMG, international kidney monoclonal gammopathies, classify those diseases. And for those diseases, it is not VCD, but mostly now anti-CD38 plus bortezomib treatment, or if there is a lymphoma clone, rituximab-based treatment. And often we have not identified the clone, but we have only depositis in the kidney. So if we don't know, it depends on the nature of the isotype of the immunoglobulin, IgG, IgA, or light chain only. We use anti-myeloma treatment, and for IgM gammopathies, we use rituximab-based regimen, but mostly combined with alkylating agents like bendamustine. Of course, those treatments, those regimens, are based on the Andromeda study in AL amyloidosis, demonstrating the superiority of the association of daratumumab and VCD. I know, I think you all already know the results, with impressive results, about 60% of CR, the renal and cardiac response, more than half of patients, but a slight increase in infection. And this is the main recommended treatment today for the first line of newly diagnosed AL amyloidosis patients. And we were very surprised but impressed by the efficacy of anti-BCMA bispecific antibody in this study with 17 patients with mostly with multiple myeloma associated AL amyloidosis, but anyway, 88% of response, every patient with improved patients with 88% of VGPR at least, and also very rapid response with level of light chain of about 1 milligram per liter, which we never observed so low level of immunoglobulin. Of course, there were some toxicities, but very manageable. CRS, one patient with ICANN, and it was also very we observe patients with who stopped early the treatment for toxicity, and the response continue. And so we think at the very small course of the treatment could be translated in a long-term response in those patients with a low tumor burden at the diagnosis. And now, as you know, there are many studies, of course, small studies, but with ADC and mostly with teclistamab, bispecific antibodies, and all those studies are in the same way for the huge and impressive efficacy of the bispecific antibodies, and some data about also efficacy of CAR T cells. So now there are a lot of 2D clinical trial running, especially the EMN protocol for teclistamab in rare amyloidosis. And as you know, this study is now running with inclusion criteria of AR patients with at least one prior line of treatment, including PI and anti-CD38. We think that the first course is weekly after the step-up dosing, and we think about 2 to 6 cycle, a maximum of 12 cycle. And the main endpoint is hematologic complete response after 3 cycles, and of course a secondary endpoint including overall response rate, VGPR, and also duration of response, organ response, and also quality of life. What about CAR Ts in AR amyloidosis? There are now some data, including very small series with cilta-cel, but also the first case published by the Spanish CAR T. And the largest study is from the academic CAR T from Israel, 16 patients with a very impressive response rate, including patients with very advanced cardiac disease, 3A and 3B. But I think we will have managed with the toxicity, cytokine release syndrome, but also cytopenia. And some patients in this study already relapse. And I think it is of course, the choice will be difficult, but we have now largest experience with bispecific than CAR Ts. Well, the second category is autoantibody activities or immune complex, and I will choose the disease with xanthoma or necrobiotic xanthogranuloma, which in those patients there is a normal cholesterolemia, but there is hypocomplementemia, meaning that there is a complex between the monoclonal component and apolipoprotein in the serum. And it leads, we don't know exactly how, but it leads to enhanced lipid accumulation in the macrophages. And those lesions, mostly cutaneous lesion, but also some organ lesions also. And we it is to distinguish between other disease, mostly Ardagh-Chester disease. But you know, in this disease, there are major criteria with histological feature, with infiltrate and large cells with lipids and cholesterol inside. And as minor criteria, you have the monoclonal components, mostly IgG kappa, but it will be also possible to have lambda components, and also periorbital distribution with very characteristics. And as you can see, the treatment IVIG can be partially efficient, but mostly treatment with steroids and also treatment targeting the clone. And there are many more and more data reporting the efficacy of treatment against plasma cell disorder, including lenalidomide in these patients with regression of the periorbital lesion, and this patient with treated with bortezomib, and the last patient with a combination anti-CD38 lenalidomide dexamethasone treatment. So it's very important to see that targeting the clone leads to the remission of the cutaneous lesion. Well, the third category is a cytokine overproduction, and I will take as an example the POM syndrome. POM syndrome with characterized by polyneuropathy, peripheral demyelinating neuropathy, plasma cell disorder with monoclonal component almost always lambda, for the light chain, and other characteristic, mainly increased VEGF, which is responsible for mostly all symptoms of this disease. Endocrinopathy, monoclonal component, of course, and skin changes. And you can see here glomeruloid angioma, white Nile, and also acrocyanosis. And in this disease, you have overproduction of VEGF, not by the tumor, the clonal plasma cells, but we think that it is mostly secreted by the normal plasma cells in the microenvironment. And what is very characteristic is the preferential use of a variable region of the light chain, lambda light chain, with a 1401 or 4401. Is very characteristic, and it is a diagnosis criteria. So in this disease, targeting, of course, targeting the clone is very efficient. The treatment is autologous transplant for systemic disorder and transplant eligible patients. But you have also lenalidomide, and lenalidomide was used also because it was anti-angiogenic treatment. But you have recently some cases treated with anti-CD38, of course, and also one report with the CAR-T, anti-BCMA CAR-T. And now we use a combination with daratumumab and anti-CD38 and lenalidomide, is very efficient in those diseases, having a prognosis, a good prognosis, in fact, if the disease is diagnosed early. And we had the opportunity recently to treat patients with relapse refractory PROMS syndrome. As you know, you can see the patient has 5 prior lines of treatment, and the use of teclistamab leads to a huge decrease of the lambda light chain, and also a decrease of the serum VEGF, and also all symptoms, including the cervical lymph node, and there was Castleman proliferation, Castleman disease in those lymph nodes, and the treatment leads to a complete remission of all those symptoms. It was very impressive, and the treatment was stopped after 1 year, and the patient is still in good remission. The other cytokine-related syndrome is TEMPI syndrome. It's not VEGF, but it is EPO, erythropoietin increase. In this syndrome, you have telangiectasia, you have erythrocytosis, you have a monoclonal gammopathy, and a very characteristic perinephric syndrome, fluids effusion, and also intrapulmonary shunting. And there is, of course, a few patients, about 30 patients described in the literature. And those patients, in those patients, the treatment targeting the clone is very efficient because you know all those publications by Sachs. You have a patient treated with bortezomib, leading to the remission of the telangiectasia. You have the same patient relapse treated with daratumumab, and it was also a very good remission. And the patient relapsed and had the opportunity to have bispecific teclistamab, and you can see here the decrease of the M protein, the decrease of the EPO level, and also hematocrit decrease. So it's very important to have those tools, the therapeutic tools in those patients, because I think it has not to be a long period of treatment, and you can have less toxicity. The last categories of treatment that we can have is for unknown mechanisms, MGCS of unknown mechanisms. And I will choose the papular mucinosis and scleromyxedema, which can lead to skin fibrosis and have those cutaneous lesion. But you can also have extracutaneous lesions and severe involvement, including dermatoneural syndrome, beginning as a flu-like fever, then seizure and coma. It's very difficult for to think about it. The disease is not known. Can have also cardiac failure, and the IVIG are initially very efficient, but it's a transient efficacy, and we have mostly most often to consider antiplasma cell therapy. You know that those patients have a characteristic in serum electrophoresis from the characteristic migration. It is most lambda than kappa. And you know, histologically, you have mucin accumulation in the derm, and also fibrosis and fibroblastic proliferation with the 3 main characteristic histological for this disease. And we will have with a French series of 33 patients, have an algorithm for the treatment, and we for severe complicated forms, of course, we will propose to have IVIG, but also plasma exchange, which are very, very efficient, and then continue with anti-plasma cell and IVIG until complete remission for those patients if we want to exclude, to avoid recurrence of the complication. But for mild disease, non-complicated disease, we can use first IVIG, and depending on the clinical response, we can switch with the anti-plasma cell therapy. And we have the opportunity to report a series of 8 patients treated with anti-plasma cell treatment, leading to, as you can see, clinical response and hematological response, very efficient. And in those patients, mostly we can stop the treatment by IVIG, and those patients, some with complication, dermatoneural syndrome complication or cardiac complication, have not relapsed. So if you have to resume, you can have to target the clone, mostly MGRs, but also other MGCS, distinguishing the plasmacytic or lymphoplasmacytic nature of the clone. You can have IVIG. It can be used in some MGCS. I will not have time to list all the disease, of course. You can have specific therapies, anti-cytokine, like in Schnitzler syndrome, with the IgM leading to inflammatory syndrome, and very efficient treatment with IL-1 receptor antagonist. You can have anti-complement in C3 glomerulopathy, and you have also to consider therapeutic abstention and surveillance if the lesions are mild, only cutaneous, and will not lead to organ deterioration. So I think it's the prognosis of those patients is good for scleral myxedema, even if you have dermatoneural syndrome, but the important, as in other MGCS, is to reach, the aim is to reach the complete remission, immunofixation negative for those patients. It's the same. And we can, if we have to resume, you can have an algorithm for the treatment of MGRS, MGCS, depending first on the severity of the disease and the complication, leading to surveillance if not, if asymptomatic and not organ treat. And if you consider treatment, you have to ask if there is an alternative to clone targeting, maybe IVIG or other, or steroids or other, but also you have to, otherwise you have to target the clone, distinguishing because plasma cells and lymphoplasmacytic. And if you have a plasma cell directed therapy, you have to consider, of course, the 3 class, I think I would say classical class of the treatment, but now new immunotherapeutic agents, especially bispecific antibodies, that are very, very efficient. And for the duration, I think with bispecific, you can have a short course of treatments for those patients. And this is my conclusion. But for bispecific, it is very, very unprecedented rapidity and depth of response. And it is off-the-shelf treatments. You can have fixed durations, so short period of treatment, so to mitigate the side effects. There are more bispecific, more targets to come with GPRC5D, FCRH5. You can have soon trispecific in development in multiple myeloma. So I think it should be tested in frontline for those MGRS, MGCS most as soon as possible. And for CAR T cells, I would say it is very practical because there is a one-shot therapy, but we have to consider toxicity. But also in CAR T development, there are also other targets, the dual targeting, a new construct, and also, as you have heard here, there are CAR macrophages, also at least preclinical data about CAR macrophages to improve AL depositis resorption. I think it will be maybe an interesting tool because the problem with AL amyloidosis is often that we can have difficult to have a removal of the depositis. And in the next future, we'll have maybe an in vivo approach for CAR T cell. So I would like to thank you for your kind attention and maybe ask for some questions. And I see in the chat.
No question, Professor Arnulf.
Okay.
If anyone has a question, please write down in the chats. Don't be shy. I think it was a very comprehensive and impressive presentation. So we are waiting for your engagement to this conversation. Please go ahead.
That is clear for everybody. So it's very, I can make a comment.
Yeah.
Because we have the choice, in fact, for treatment, and sometimes outside of bispecific or immunotherapeutic tools, we don't know if we have to use proteasome inhibitor or IMiDs in MGCS treatment. Of course, for renal disease, prefer to use bortezomib proteasome inhibitor because it's not a problem with the renal failure, contrasting with lenalidomide. But in some disorder with cutaneous problems, and it is not a problem to use lenalidomide. And well, unfortunately, we will not have randomized studies for those rare disease, but I think we can have more data, and I think it's very important with the huge progress regarding the treatment of plasma cell disorder to use those treatments, because many of the patients with MGCS are treated with steroids and non-specific treatment, and the response is not so good and with side effects. So I think it's very important to consider anti plasma cell treatment.
Thank you, Professor Arnulf, for this additional comment to this presentation. I think that it was too comprehensive and that's understandable that we don't have any other question, if I'm not mistaken. I think that we can thank you again for this presentation and close the webinar here. If the audience doesn't have any other points to raise, I just want to have a short comment about the upcoming Thursday webinar that we will have in November about cutaneous T-cell lymphomas, bridging gaps in therapy and patient care by Martin Vermeer. Don't miss it. You have the link to register in the chat box. And we are looking forward, Professor Bertrand Arnulf, to have you again in this Thursday series, as well that this video will be published on YouTube and that you can disseminate it afterwards. Thank you very much for that and have a nice evening.
Thank you very much. Thank you.
Thank you.